Hey guys, it's Dr. Rosa. We're going to be doing a quick video here on left ventricular assist device management because we currently have a patient nearby over in Mountain View's district that has one of these devices in place, and it's always a good topic to revisit from time to time, even though I know you guys have covered this a few times before. We're going to cover this briefly here in a general sense, and then we're going to work on potentially having the LVAD coordinator and maybe the patient himself come out to a couple of the stations that are nearby to where he lives so that you guys can get a little bit of hands-on training as well. But this is just going to be general training to cover what you guys need to know. There should be a link to the PDF of the emergency booklet for LVADs, and also a link to a brief YouTube video that shows how to check a blood pressure in an LVAD patient. Although we'll talk about kind of when you need to do that and when it's not worth the time potentially. So since we're also going to put this video out for other agencies to take a look at, I just want to put a quick caveat in here that this training is intended for agencies under my medical direction. Not that I'm saying anything that's out of the box or really revolutionary, but certainly this is just going to be informational for everybody else. So if you're watching this video outside of one of my agencies, this video is strictly informational and educational, and your care of patients should conform to your training, local protocols, guidelines, medical direction, and whatever agency standard operating procedures and guidelines you have in place. So first and foremost, what is an LVAD? It's a left ventricular assist device. Sometimes it's just called a ventricular assist device. And this diagram shows you the general idea. It's a pump that sits in the upper abdomen or lower part of the chest. It takes blood from the left ventricle through a port that's stitched into it, runs it through the pump, which is like a turbine continuous flow pump, and then dumps that off into the aorta. And what this does is it gives extra kick to the to what the left ventricular is able to do. So why do we care? So first off, National Registry still requires half an hour on LVAD, so this will count towards that. And you also may run into a patient who has an LVAD. As we said, Mountain View has one in district now. Certainly patients travel all over the place with these things, so we can get someone from outside of the district who comes by, and this is just good general information to know for something that is pretty sketchy if you don't have an idea of a stepwise thing for what you want to do. So why do people have LVADs? So the idea here is that patients who have end-stage heart failure who are awaiting transplant can use this left ventricular assist device as a bridge. And it's because their left ventricle can't pump enough for whatever reason. It's scarred down from ischemic cardiac disease. They can have inflammatory stuff, post-infectious, post-viral heart failure is a thing as well, autoimmune problems, etc., etc. And what the LVAD does is it gives more push. It's an assist device. It doesn't necessarily take over all of that flow. But if we think about this, we have a patient who has a heart that doesn't function very well, has a pump that can add some kick to that, but not necessarily sustain operations all by itself. So when we think of, what could go wrong here? Obviously, a whole bunch of things come to mind. The batteries can die, the wires can become disconnected, the pump itself can fail. One common issue is that it can form blood clots within the pump, and then of course other things unrelated to the LVAD. So these people who have this generally aren't really healthy on a good day, and so they're susceptible to all the other things that folks can have that could bring them to our attention: trauma, infections, bleeding, etc. So if you have a patient who's got an LVAD, how do you know what to do? So first and foremost, the patient, if awake, is likely an expert on what to do. They get a ton of training before they get charged with these things. So they'll generally be able to help you through what's going on. The family members are also trained what to do. The university gives them a bag full of gear that has instruction booklets, extra batteries, extra cables, and many patients will keep all their stuff in that bag. It looks like the one here on the right side of the slide. There's also the contact info for their LVAD coordinator, and that's a 24-hour pager number that will go directly to that coordinator, and they call back right away. So the very first thing the LVAD coordinator told us is that should be the first thing that you do when you contact these patients, is go ahead and fire off a call to that number and get that LVAD coordinator on the line. This is the same number. If the patient's from university, it's the same number that's in our protocol set. And there's also a phone number that's separate for children's, because if we have a pediatric patient who has an LVAD, then that would be A pediatric patient with an LVAD, then that would be going through Children's Hospital and has a different phone number, but that's even more rare of a thing to see. So what you're going to do, there's a bunch of flow sheets. There's a really cool one that I saw. This is out of Scott Weingart's MCRIT website. There's a link for this at the end where it goes through in a very organized way of what to do emergent management of a patient with an LVAD. Starting off, first off, are the alarms going off or not? If the alarms are going off, we call the on-call specialist, get the travel bag for the emergency information instruction booklet, and the instruction booklet should have a step-by-step process of what to do for those alarms. The PDF link is the PDF that's in the link is the emergency booklet for the current device that they're using now, and this is June 2022 in this recording. If you are able to deactivate the LVAD alarms, then you're going to go back into this, assess the patient and see what's going on. So is there evidence of acceptable perfusion? So do they have a palpable pulse, appropriate mentation, good skin signs? If you can measure a blood pressure, if they have a pulse, that's useful. If they don't have a pulse, you can still attempt to measure a blood pressure. We'll get to that in a little bit. The patient should have some gear in that bag, a doppler that allows you to do that. If the patient is not having adequate perfusion, we do all the normal stuff that we would do to improve perfusion. And so, we'd give them a normal saline fluid bolus. Denver Metro protocol is 250 cc's. Certainly in the ED, we have the option to give red blood cells if the patient's severely anemic. Afterload reducing agents as well if the patient's basically in the equivalent of acute congestive decompensated heart failure. Treat any kind of non-perfusing arrhythmias using ACLS protocols because, again, getting the heart back to pumping as best it can is going to be optimal because the ventricular assist device and the ventricle need to work together. If you do have to apply cardioversion, don't put the paddles or the pads over the device, and then you'll see this over and over again. The CPR is a high risk in these patients because it can basically rip the pump out of the wall of the ventricle, and then they can get a fatal bleed from that. So that's basically a end of the game kind of option when we don't have anything else to do. There's mention of a hand pump in this particular flow chart, and you may see that elsewhere. The LVAD coordinator at university tells me that that's something that went away about 10 years ago. So generally, you're not going to have a manual pump. These are all electric. There will be spare batteries, and then there will usually be a cable that allows you to plug it into the wall or plug it into a 12 volt vehicle source. Heparin doesn't apply to us, and then coordinate further management LVAD's on-call specialist. So this is something for the ED to follow as well, because we're going to be calling that specialist too once the patient gets to the ED. Now, there's a good flow sheet actually in that emergency care booklet for this device, and you can see it's very similar. So first things first, get the phone call out to the pager system for that LVAD coordinator to help you out. Figure out if the pump is running. If the pump's not running, then you're basically following on-screen instructions, making sure everything's connected. There isn't a loose wire, a loose cable plug. Check and see if the battery level is good. Switch to the mobile power module if you have to, and then get the patient on EKG, look for other problems, treat per protocol, and then certainly if you're going to do chest compressions, that's got to be a last-ditch thing because that can potentially be as dangerous as whatever's going on. Now, if the machine says the pump is running, then you just go and check and see if the controller is alarming or not. If it's not alarming, then we're just going to treat this patient per standard protocols. What's going on with the patient? Do they have adequate perfusion? Do we need to supplement that? And then we transport. If the controller is alarming and the patient is stable, same deal. We just treat them and get them transported. If they're unstable, we go and we look for things that we can do to optimize that. Looking for other medical problems, get the patient on monitor, and treat. Denver Metro protocols are very similar to this. So this is 3090 ventricular assist device. You can see way down on the bottom there the phone numbers for university for adults and Children's Hospital for pediatrics. And again, same issue. Assess the patient, focusing on cap refill, focusing on skin signs, mentation, saturation, and if we need to measure a blood pressure, that's something that's possible. I'm going to go over that in a second here. So what's our general approach? Alarms, get the emergency number, get hands on the emergency booklet. If the patient has acceptable perfusion, then we're transporting. We're just moving, getting this patient to a definitive area of care. If the pump's not running or there's poor perfusion, we're going to troubleshoot per the booklet. And if the patient has no perfusion, we're going to give bolus 500 cc's at a time in one protocol. Denver Metro says 250. But basically, we're trying to get preload up, cardiovert or defibrillate, but don't apply it over the device. You don't want to inactivate the device. And then CPR is a last-ditch effort. So what about perfusion? So because this is a non-pulsatile flowing pump, the patient could have a pulse and good perfusion, just like anyone without an LVAD, or they may have no pulse and a good perfusion because the LVAD just happens to be pushing blood well enough to perfuse, and you're just not able to palpate the kick of the left ventricle. But the pump's not pulsatile. So what are the things you can look at immediately? Capillary refill, mentation, and skin signs are the three things that we can look at very quickly. Now, you can use a blood pressure cuff and Doppler to get something that's someplace between a systolic blood pressure and a MAP. The LVAD folks just basically call this a blood pressure because it's kind of indeterminate pressure. But I'm going to show you how to do that, and there's a video for that. And then keep in mind that the patient has a good pulse. That is still a good pulse even if there's an LVAD in place. So that's something to keep in mind too. Okay, so there's this YouTube video. There should be a link to that that you guys can click on and check out and watch it. It's really kind of set up for lay people who don't know how to take a blood pressure, so I apologize for the video being a little bit simplistic, but it shows the general idea. And basically what you're doing is you're taking this Doppler, which the patient should have. This isn't something we standard carry, and this is a vascular Doppler, not the lower frequency Doppler that we use to check for fetal heart tones. So this is a higher frequency, more superficial Doppler for checking for arterial flow. So what the Doppler is detecting is turbulent flow in an artery, which is the same thing we listen to, the Korsakoff noises, when we're taking a blood pressure. So basically what you're doing is you're going to listen with the Doppler over the brachial artery instead of with a stethoscope. So you're going to find that turbulent flow over the brachial artery. You're going to leave the Doppler head over that while you inflate the cuff until it goes away, until that flow sound goes away, and then we've basically occluded the arterial flow. And then as we release it, that flow is going to come back. So you can do this in a normal person too, and a person who doesn't have an LVAD. And that first flow that you're going to hear is going to be their systolic blood pressure, because that's going to be the highest peak pressure that you have in the artery. In the LVAD, that number either can be the systolic blood pressure if they have a strong pulse. It can also be the mean arterial pressure if the patient doesn't have very much pulse at all, or it can be kind of somewhere in between those two numbers, depending on the ratio of how much contribution the ventricle is providing versus the LVAD. When you report out that number, basically we just simplify this. We say the blood pressure with Doppler is whatever it is, millimeters of mercury. Also, I want to make sure that we don't mess around with this too long. Sometimes we can get caught up in the technology and we can be trying over and over again to use a new gadget to try to measure a blood pressure while the patient's decompensating in front of us. So if we're doing this, we definitely want to be doing it as we're moving forward, or we're doing it in a patient who's relatively stable and we have a little bit of time to mess with it. So again, don't get down into this rabbit hole if you've got more critical things to be handling. Just look at the perfusion signs and work off of those until you get either enough hands or you get the patient someplace we can measure this. So what's the take home? First off, it's pretty rare for us to see an LVAD patient, but when we do, we want to have some steps to engage with so that we can make that less stressful for us and more likely to have a good outcome. The patient will generally have information to tell you or on their person. Do not jump right to CPR. It can kill the patient, which goes against a lot of our training in CPR in general, where we talk about how CPR is relatively benign and delaying it can be harmful. This is the one patient where that's the reverse. We want to make sure the patient is actually not perfusing if we're going to start chest compressions. If the patient's already dead, you have nothing else that you can do. No reason not to try chest compressions. It may actually salvage the patient, but we want to make sure we run through all the other options first. And then the destination depends on patient acuity. So where we are for North Metro and Lafayette, we're relatively far from University, and that trip is a very long and lonely drive. And so there's no place to kind of stop if the patient decompensates en route. So it's some patients potentially, if they're relatively stable and we feel comfortable with that, we might make a run for going to the University, or if it's a pediatric patient, Children's Hospital, which again is going to be even more rare. In general, these patients are touchy enough and potentially sick enough that really the best option is to go to the nearest hospital-based emergency department. that's going to have the resources to get this patient stabilized and then potentially load up an air transport over to the U or over to Children's. But again, depends where you are, and obviously if you're listening to this video and you aren't in one of those two agencies, the transport pattern is going to be dependent on where you are, how far out you are, and your local leadership directions. So the references we have on here, there's the MCRIT link. That actually requires a subscription. It used to be free, so that might come up as a bit of a broken link. The MyLVAD.com has the information on it, and then the YouTube video link at the bottom, it goes through how to measure a blood pressure in a patient who's got a left ventricular assist device. So anyway, thanks for taking a look at the video. Take a look through the handouts and watch that other YouTube video if you get a chance, and let me know if you have any questions. And like I said, if you're in one of those stations nearby to where this patient lives, we're going to see if we can get some additional hands-on stuff and in-person training on top of that. Thanks for all you guys do. Keep up the hard work, and let me know if you guys need anything.